And our last speaker in this session, Dr. Marc Triola. Many of you know him in the room. He's our Associate Dean for Educational Informatics and Director of our Institute for Innovations in Medical Education at NYU. The title of his talk is Using Education and Clinical Outcomes Data to Assess Performance.
Thank you very much. And I also wanted to acknowledge and thank the AMA and Susan, whose consortium have been funding a lot of the innovative work that built up to what I'm going to be talking about today. And I'm going to take a little bit of a different perspective as to close things out, where the unit of analysis of thinking about measuring success is really at the level of our schools rather than the individual learner. And thinking about how and if we can answer these fundamental and pretty basic questions, ones that are, to a certain extent, much less granular and sophisticated than the nuanced ones we want to ask of our students. But are our medical schools and our medical education programs successful? Do we prepare our graduates for the needs of their future practice? We've been talking a lot about their residency training, but how about their practice 10 or 15 years from now? What are they doing? What specialties do they choose? What procedures are they performing? What types of patients do they see? And could we use that information to think differently about how we're teaching and preparing them? And then we as a school, or we as a country, or we as a continent of medical educators, what impact are our graduates having on the healthcare system and the patients that they're taking care of? And how can we do comparisons? How can we compare our school to others? And as we heard about this morning, how significant is that imprinting effect? Is it all washed out when our graduates go on to GME, or is there a long-term effect? Really, the long tail of the effectiveness of what we're doing during medical school lies in independent practice. That's where the real non-proxy, the real outcomes are. It's very difficult for us to measure these things. Our learners crisscross institutional boundaries back and forth between fellowship and GME practice and others. There is a pretty minimal feedback loop between our graduates in practice, clinical practice, and our school's curriculum, and the advising and mentoring we give our students. And there's really very little data beyond GME training. And yet, we are in one of the richest fields for data, and we have one of the greatest opportunities for data and this longitudinal approach to really create this continuously learning healthcare system and continuously learning medical education system that we aspire to. We collect data on our learners all the way through the levels of training and into clinical practice. And it is this world in clinical practice that I want to focus on. When we think about this educational data continuum, and this diagram is to scale, undergraduate training for 4 years, medical school for 3 or 4 years, GME for 3 years for somebody like me as an internist, and then clinical practice, our density of education data is pretty minimal. And our density of attributable patient data and outcomes is really the thing that we have the largest signal in. And as we enter this era of electronic health records and really comprehensive data, the reality is a mountain of electronic and clinical data. So can we use new resources like open data from the federal, state, and local governments to understand the impact and understand the quality and the efficacy of our workforce that we as medical schools are producing? There has been a surge in open data being released from CMS, from NPPES, from data.gov, and in our case here in New York, think data sets like Sparks that Susan mentioned. And this really started in 2012 when Obama signed a transparency memo. This data is really largely de-identified at the patient level, but very identified at the individual practitioner level. You would be shocked to know how much data there is out there on each of you who are in practice. And all of these data are linked by the National Provider Identification Number. These are all free and open, no login to download, no IRB. No permission, no data sharing agreements across our institutions. So we are particularly intrigued by this data set, which was from Medicare, called Physician Compare. And Physician Compare is a data set that links our graduates, the year they graduated from our medical school, their NPI number, which is the unique identifier for all providers in the United States, and where they're practicing, and all sorts of information about their practice. As a caveat, this is only those physicians who are in Medicare. So as an experiment, we took this Medicare physician compare database and tried to understand how much we could tell about our medical school and all medical schools as a whole. We used some informatics trickery, and we tried to really understand and extract how we could attach graduates to individual medical schools. We decided to stick with schools that were in AMCAS who had graduates prior to the year of 2000, which was 128 medical schools. And we were able to successfully identify 332,238 graduates of all of our medical schools from the years 1939 to 2016 who are in this database. It's about 40% of all of our graduates. It's a skewed sample. So as I show you some of these results and graphs, this is a skewed sample that's focused on Medicare participants, which does not necessarily reflect in the unique distributions of each of our medical schools. I don't know how well this projects, but this is just the top 20. You can see many of your schools on this list in terms of the name of the medical school, the state that they're in, the number of graduates that we could find in the database, and the earliest year for which there were graduates in the database. So up here, Indiana's at the top with 6,748 graduates in this database. And here's NYU with just over 4,000 from 1944 on. It's pretty astounding when you think that most of these folks graduated from medical school 10 or 15 years before Medicare and Medicaid were even a twinkle in the government's eyes. And here we are looking at this data. So what can we do with these data? Well, certainly we can do workforce analysis, and historically that's what these data have been used a lot for. We can look at and compare the practice specialties, again, remember through the lens of Medicare participants, the practice specialties of all of the graduates that we have in this database, and compare our medical school to all others, and see very happily the prominence of internal medicine, which is my specialty. And understand what type of doctors we are producing, which is something that is surprisingly difficult and elusive at this level, at the population level. We can also look at practice locations, and through this we can look at a tremendous depth. And I'm not going to go into it all very briefly here, but we could tell a lot. In this database are the number of providers in each of these practices, the types of patients that they see, where they are, and then the zip code through there we can get the census data to understand that. But this is a pretty neat ability for us to be able to map where our graduates are in practice throughout the United States, at least those who are participating in Medicare. And then we can use other data sources to really understand what specific diagnoses our graduates are seeing. Here in New York State, we have a database called SPARCS, which is very detailed information on every single inpatient admission to the hospital that's also released for free. And so we can compare all graduates of all medical schools and the most common admissions they saw inpatients for in the hospital. And as Susan pointed out, hospitals are about delivering babies. And compare all graduates from all medical schools to our graduates. And though this is just a first pass, you could think about how a residency program or curriculum committee could reflect upon what our graduates are looking at actually in practice and slice and dice these data to really understand specifically what different populations of graduates are looking at. Then we can begin to think about really interesting things about the impact of the mission of each of our medical schools. So for example, I just took a quick look saying, in this Medicare database from 2014, what did NYU graduates do? Well, our graduates of our medical school, just in 2014 alone, saw 1.5 million patients in outpatient visits nationwide. That's a pretty amazing and profound impact. And using that SPARCS database, we could see that they were the primary attendings taking care of 52,500 inpatient admissions across the 227 hospitals across the state. Just for fun, I looked at the number of days of statins that our graduates prescribed in 2014 for those patients who had Medicare Part D. 22,500,000 days of statins were prescribed in 2014 alone. 300,000 ECGs ordered on Medicare patients, and 150,000 CT scans ordered or interpreted on Medicare patients. So a pretty interesting and unique look that we could think maybe really could feed back to our understanding of the impact of our medical school and at least give us perspective on what we're doing out there. So that is all workforce type data. We want to also look at quality data. And there are some interesting things that we can do with these data to look at measures of quality. Some of them we have to figure out on our own. Some of them are quite explicit. One of the things that we did was we took the Medicare Part D prescriptions, and believe it or not, if you're a physician who participates in Medicare Part D, every single one of your prescriptions is open for free online for the public to look at. How often you wrote generics versus expensive medications, how much the taxpayers paid for the prescriptions that you wrote, every single one. And one of the outcomes that's been looked at a lot is benzodiazepine prescription in patients over the age of 65, and how often that's done with a goal of reducing that over time. This graph takes each of our medical schools as a blue dot. So each blue dot is a separate medical school. Along the bottom are the number of graduates in the database that medical school has. So if you remember, from our cheat sheet in the beginning, this dot over here is going to be Indiana. And these dots over here are schools that have smaller class sizes or are more recently entered in the database. And along the left, this is the percentage of prescriptions for those who prescribe benzodiazepines that were done in patients over the age of 65. And what's pretty remarkable about these data is it does look like that there is a regression towards a mean of 2% among schools that have more graduates in this database, and there's really a narrowing down and a regression towards that mean, which is pretty fascinating and could be used to go back and reinforce the individual curricula at our school around a particular pharmacology intervention. Well, maybe this is an effect that doesn't have to do with the number of graduates, but the year that students graduated from medical school. So I looked at the year of graduation from medical school and the percentage of medications that were prescribed, the percentages of benzodiazepine prescriptions in patients over 65. And this is really pretty interesting. The blue line is the trend line for all medical schools, and it would appear that, that people who graduated from medical school farther back are prescribing more benzodiazepines to patients over the age of 65. And in this case, the red dots are our graduates at NYU year by year. And though this is not methodologically sound, what's really interesting is that you can see these flat lines and then a bump and then a flat line. And those correspond to our two curriculum reforms, which both included a pharmacology revision. And so this is pretty interesting because though, again, there are a million confounders between graduating from medical school and writing a prescription years later, you can definitely see a trend here. Now, this is data from PQRS, which is a voluntary quality program within Medicare and Medicaid. Very few physicians actually participate in this and report data, but for those who do, they report data on whether or not at each visit they are screening for things like depression, smoking cessation, high blood pressure, and other health behaviors. And what this shows us actually is that if we're looking at specific trends, this looks like the older physicians are actually doing a better job at office-based screenings across many of these things as compared to others, which is actually pretty fascinating and interesting. One wonders if things like work hour limitations or the frenetic nature of the modern medical school and the more experience of these prior physicians comes into play with that. But this is a really interesting use of what is quality data that's already out there and the ability to break it down. Since these numbers are small, I didn't break it down by an individual school, but those data are there as well. Within the Sparks data here in New York, we not only have access to, for each visit, things like length of stay, but we also have access to cost data. And I took a look at all of the patients who were admitted to the hospital in 2014 for CHF in New York, about 55,000 admissions, and looked at which medical school the attendings went to by most common medical school. So no surprise that the New York medical schools are producing the doctors who take care of the patients here in New York. But isn't it fascinating that we can, using these public data, look at the number of graduates, the number of admissions, the differences in average length of stay by physician, and the differences in average costs? If the hypothesis of imprinting is true, then these data are meaningful. If GME is truly the definition of where you develop your clinical habits and practices, where then you enter a healthcare system that really dominates how you work, then these data are meaningless. But what a neat opportunity for us to have to be able to use all of this, especially since it's open and free. So I think we think that these data could really begin to provide new insight into this long tail of the educational continuum, and potentially provide one more loop as part of that feedback loop to our UME and potentially GME programs, and that these quality and system level data can inform our curricular planning, transition to residency programs, assessments, mentoring, coaching, and more. As I mentioned, the data are vast. There are millions upon millions of rows of data, but these really are things like Medicare participants, which don't reflect the entirety of our graduates. There's a long delay from when students enter medical school and complete 4 years of medical school and a bunch of years of training and then go into practice before they really appear in this database. It's close to a 10-year delay. And additional data sources, such as the AMA master file, which has much, much finer grained information on not only all of our UME graduates, but all of our GME graduates, could provide a much richer perspective on this. But given that this is out there, it's open, it's free, and we can empower our students, our residents, and our faculty to use these data to answer questions in interesting ways, I think it's one avenue that's really going to provide some great opportunity in the future. Thank you.
Open it for questions.
Medicaid, are we able to access Medicaid data similar to Medicare?
So in terms of the list of providers and where they went to medical school,
Yes.
that's through Medicare.
Right.
There are Medicaid databases that are available, like individual provider utilization data. So you can look at through Medicaid what specific procedures were done, office-based visits. There's a treasure trove, really, and the sky's the limit at what's out there. The data definitely have limits, but there's a tremendous amount that's out there. And what the opportunity is here, especially with the AMA, the AAMC, and the ACGME, you guys all have the data on our learners, on who they are, where they train, what their levels of education are. And if we could link that to these national provider identification numbers, then we can link back to our communities, the health, and everything that they've done in a really rich way. And all of the issues of IRBs and the challenges of cross-institution and cross-school collaboration kind of fall away when we're using this open and public data.